This installment of the Crucible examines the medical legal aspects of checklists, and the paper comes from the New England Journal of Medicine in 2014, and it's titled Introduction of Surgical Safety Checklists in Ontario, Canada. The authors evaluated all acute care hospitals in Ontario to determine when surgical checklists were adopted. They then compared operative mortality, rates of surgical complications, length of stay, and rates of hospital readmission among patients undergoing a variety of surgical procedures before and after the adoption of a checklist. The study involved 101 hospitals, which performed 109,000 procedures in the 3 months prior to the checklist and 106,000 procedures in the 3 months following the adoption of the checklist. After a thorough analysis of the data, the authors concluded, and I quote, implementation of surgical safety checklists was not associated with significant reductions in operative mortality or complications. The idea of using checklists was borrowed from the field of aviation, and I happen to be an instrument-rated pilot. I have about 2,000 hours of flight time, so I'm somewhat familiar with this. And it's true that checklists are an integral part of flying, and in certain situations their use is required by the FAA. However, they've never been shown to improve safety. The Navy did a study on this and found that neither checklists nor crew resource management, which is a fancy type of teamwork, neither of them had any effect on accidents or incidents by Navy pilots. Now, despite that, an idea was hatched that checklists can improve patient safety. And I know that's not logical, but it's how the medical legal field operates. So an initial study was done, and it showed that checklists reduce surgical complications by 30 to 40%, which was astounding. And everyone in the patient safety and medical legal field immediately embraced checklists. The problem was that these results were too good to be true. So this Canadian study was done, and they found that checklists didn't have any effect. So how do we reconcile this? Well, the initial study, the one that showed the incredible benefit, was a multinational study, and many of the sites were in third world countries. And this is important because surgical checklists include items that aren't customarily available in third world countries, things like pulse oximetry. So in order to comply with the checklist, the centers in less developed nations were forced to obtain pulse oximetry so that they could provide it during surgery, which is something that they otherwise wouldn't have done. Of course, when you add technology that you didn't previously have, you deliver a higher level of care and you get better outcomes. However, when you repeat the study here in North America, where we already use that technology, the checklist had no effect. Now, in addition to the lack of established efficacy, we need to remember that checklists also have risks. They can divert attention away from the patient or interfere with workflow, and over-reliance on checklists can reduce the ability to detect other types of errors. These potential problems were noted in a recent review article where the authors concluded, and I quote, numerous implementation issues remain, including how to modify a checklist to a specific hospital setting, or a specific anesthesia system, or a specific surgical staff. In other words, we've still got a lot of work to do. Now, if you believe that the practice of medicine is based on science, then you have to say that checklists are unproven and cannot be broadly recommended. But as I've said before, the risk management field operates independent of the literature, and there's a continued push for the universal implementation of checklists in all sorts of settings. The problem with that approach, aside from the fact that it wastes resources, is that it creates a worrisome legal situation. You see, we've got a growing list of entities, Joint Commission, patient safety groups, insurance companies, and so on, that are recommending the use of checklists. And this creates a situation where someone, a lawyer, can argue that checklists are the standard of care. You see, if everyone's recommending them as a way to save lives, then they must work, and they must be the standard of care. And that means that if you don't use a checklist and your patient dies, then you're on the hook because you violated the standard of care by not doing what all these experts recommend. Now, you might say, well, what about the data showing the checklists don't work? Well, that's our defense, and we'll certainly argue that. But it's not easy because we're up against best practices and position statements from all these big name entities, and those things impress juries, which means that we might lose. And as you've probably figured out, the end result is that you could follow the literature and practice evidence-based medicine just like you're supposed to do, and you'd lose. And this is what happens when people implement patient care standards without regard to the scientific literature, and this phenomenon is rampant in the medical legal community. Thanks for listening.